doing this.
Move on to what we call surface landmarks. Now, what's a surface landmark? Well, it's a landmark on the surface. There you go. You got it for your test. No, it's more than that. Surface landmarks are what we use to palpate on different areas of the body. We're going to use these surface landmarks for identifying centering points, positioning points, everything we do with an x-ray. The very first one you guys are going to learn next week is how to locate the vertebral prominence, or C7. Does anybody know how to locate that specific vertebrae? Well, if you reach to the back of your neck right now, that prominent vertebrae poking out in the back of your neck, close to your shoulders, is C7, or the vertebral prominence. We locate that landmark to position properly or center properly for a chest x-ray. Because, let's see, Jordan, since you were late, I'm going to pick on you. Come on up here.
Thank you. Thank you.
Jay, I'm sorry, Jay.
So I felt like I was in trouble again.
So Jay, face the wall there. Face the wall.
See another patient, don't want to.
So you will locate your vertebral prominence. Like I said, you gotta get used to touching people, by the way. And don't just start prodding on Jay's back. Jay, can I poke on your neck to find a certain point, the center? He's gonna say, okay. I'm gonna feel for that vertebral prominence. Then we'll make this symbol right here. I'm gonna put my pinky on the vertebral prominence and then my thumb down right here. And guess what? That is my centering point. That's what we call T7. That's where I put my central ray, or my target for a chest x-ray. So these landmarks,
Pinky to thumb.
yep, pinky to thumb, these landmarks are important to find these centering points, because it's ideal to not only position the patient correctly, but you got to center correctly to get that optimized image. So that's the importance of these surface or these external landmarks. Thank you, Jake.
So what was that thing you got here on the top?
The vertebral prominence, or C7. We're going to go over those in a second. I got a picture for you. So table 3.1 in your book is going to summarize most of the important landmarks we're going to start with. I got it on the next slide as well. And this is what you're going to start practicing next week. You got to master these surface landmarks. And they're all over the body. Yes.
Do we also see it on the...
Yes, you can. It's, let's see, right here. Right here, so those prominent. Spinous process, what that's called. The most prominent spinous process of the C vertebrae.
Do you have them like lean forward, or?
You don't have to have them lean forward. You can feel it pretty easily on most of your patients. Now, another example before we move on. Let's say your patient's laying on a backboard or a table or a bed and they can't move. Well, what in the world would you do? How would you find your centering? Well, we have alternatives like we talked about before. There's what's called the jugular notch right here. We can use that and center a little bit below the jugular notch, about 3 inches below, and that'll still line up with T7. So we have alternatives to those landmarks as well, whenever we have like traumatic patients, different situations, until you learn to eyeball it. All of you here are gonna gain a very special power as you get through this program. You're gonna be like Superman, you're gonna have real x-ray vision. Now, what am I talking about? You're gonna be able to walk up to a patient and see their skeletons in their body and know exactly where to put your centering points without even having to touch the patient. That's what we're going to develop over the next 2 years. You're going to start as babies at first, using those surface landmarks. Techs are going to be laughing at you and say, why are you doing that? What's all this about? But you're going to learn to develop that x-ray vision. And I'm telling you, it sounds crazy, but you'll be able to see the skeletons in the body. I can look at each of you right now and see your skeletons. I can visualize it in my head. We'll get to that point. That's what we're going to work on. So here are the most prominent landmarks that we're going to begin with. There are a lot more than just these. But some of the major ones that we're going to hit in this chapter, let's start at the top here, the TEA, the top of the ear attachment. That's really the top of your ear, right here, the TEA. We use that a lot on our head work. Mastoid tip, if you go behind your ears, right here, you can feel a little prominent process. That's what we call our mastoid tips. Mastoid tips. We're going to use that for soft tissue neck x-rays that we're going to learn about in the next chapter. Then we have that vertebral prominence, also some prominence, or C7. That's the one in the back of your neck for those chest x-rays. The jugular notch here in the front, which we can all feel right under our neck. That's that jugular notch, the top of your sternum right there. Now, two that you cannot palpate, don't go palpating this on your patients because you're not going to find it. The thyroid cartilage and the hyoid bone. But what we do need to know is basically where they lie in relation to the vertebrae. The hyoid bone is approximately usually between C3 and C4 in this region. The thyroid cartilage is typically at the level of C5. Know these levels of this anatomy. They do like to ask questions on that, especially over here when we come to this next. Last one, the gonions. It's not gunion like onion, it's gonion. That is the angles of your mandible right here, poke right here. Now those are your gonions. Another palpable landmark that we're going to use, especially in regards to head work. Now let's look at the rest of the body here. T1, T2, and T3. T2 and T3 are at the level of the jugular notch. That is very important to know. Write that down. You need to know how that anatomy relates to the vertebrae that they line up with. The jugular notch is at the level of T2 and T3. T7, another palpable landmark. If we don't want to use the vertebral prominence, we can also use the inferior borders of the scapula. If you poke on a patient's back, and you'll do this next week, you can feel the angle of the scapula. That's back here, by the way. Angle of the scapula is this point right here. You can feel that on most of your patients. That also lines up with T7. That's another way we can center for a chest x-ray. So the inferior angles of the scapula are at the level of T7. Boy, that's a good test question. I felt that one. T9 and T10 are at the level of the xiphoid process. Where's the xiphoid process? Does anybody know? It's on your picture. That most inferior end of the sternum right here, that little point. It's your xiphoid process. It's at the level of T9 and T10. Inferior costal margin. Inferior costal margin is a fancy way of saying the bottom of your ribs. Yes, sometimes you have to palpate that area. Yes, sometimes your patients get ticklish. I'm a very ticklish person. I hate when people palpate me there. We have a lot of students that get ticklish, but that inferior costal margin is the most inferior portion of your ribs. That's at the level of L2 and L3. Big one here. Put a big star on that one right there. That's one of our main palpation points, especially in the abdomen. The iliac crest, once again, the top of your pelvis. You can feel that right now if you feel the top of your pelvis. That's your iliac crest. That's at the level of L4 and L5. Then we have what's called the as-is, another palpable landmark right out here. That's at S1. S1, as-is, anterior, superior iliac spine. And then the coccyx and the pubic symphysis are at the level of what we call the greater trochanters. The greater trochanters are these little ridges on the side of the femur, right here and here, on the skeleton. That's your greater trochanters. You can feel it if you wiggle your toe. You put your hand on your hip and wiggle your toe. You usually feel that femur shifting. It's your greater trochanter. Now, why is that important? All these are palpable landmarks. Don't go palpating people's pubic symphysis. Probably don't get slapped in the face. That's a very old school palpation point. I actually worked with some people that used to palpate there because they were like doing x-rays in the Stone Age. That used to be an acceptable palpable area. It is not an acceptable palpable area anymore. Do not palpate your patient's pubic symphysis. Instead, we can use the greater trochanters on the side of the hips. Typically, you just have to wiggle their leg or their foot. You can feel those greater trochanters. That's at the level of the pubic symphysis. And we can find our centering points once again. So as you can see, this covers a large portion of the body here. And we can find our centering points by using these palpable or surface landmarks. These are all extremely important, guys. I would put a big star on this image right here. Make sure you know at what level each of those landmarks falls in regards to the spine. There's numerous questions right here, guys. There's a bunch of questions I could ask right there. Memorize those and those like the back of your hand. We're going to use those throughout all of your tenure here in X-ray school. And once again, I can't say enough, make sure you ask permission before you start poking on your patients. Now, sometimes we get excited, we jump in there, we just start wanting to get our hands on people. No, communicate, communicate, trust me. Especially this day and age, people want to sue you for just looking at them wrong. All right, so body habitus. We're going to talk about the different body habituses. There are 4 main body habituses that we're going to talk about. These are going to be the variations of the shape of the human body. You have your average shape and you have your extremes. Average and your extremes. Now, why are these important? Because like I said before, especially when it comes to fluoro, when we learn about fluoro exams, these organs are going to lie in different locations of the body depending on that specific body habitus. So it actually determines the size, the shape, and the position of those organs within those cavities we just talked about. Now, most commonly, we're going to focus on what's called the sthenic body habitus. The sthenic body habitus is the most common type out there. Therefore, all the diagrams that you typically look at in a book are based on the sthenic body habitus. We do have other variations that we're going to talk about here. Yes?
So is this similar to like mesomorph, ectomorph, and things of
That's
that nature?
more on the skull.
Okay.
Yeah, which we'll get to that as well later,
Okay.
a couple semesters down the line.
So I don't know the term stomach, it's STI.
Yep, coming up next.
I just don't know what.
I'm talking ahead. It's coming up. There's a great chart in your book, by the way, on those body habits. Just put a big star on that. Pink charts. Now, what organs are affected specifically? These are the ones right here. These organs specifically will vary in shape, size, and location of the body based on those body habits that we're about to name here specifically. The heart, the lungs, the diaphragm, your stomach, colon, and gallbladder. Stomach and colon usually are the most extreme examples, but the lungs have quite a bit of variance as well. I'll tell you right now, I hate doing x-rays on skinny people because their lungs are super long. And you have to do like an upper and a lower x-ray to get it all on there. I mean, they have, especially if they're athletes and they're skinny, those lungs are massive. Massive. I saw Miss Bonilla smiling back there. She knows what I'm talking about. You usually see a skinny person like, yeah, skinny person, that's the easiest one. No, it is not. You just have to do multiple x-rays. And there we go. There's our four major types of body habits: the sthenic, the hyposthenic, the asthenic, and the hypersthenic. Now, the most common type is sthenic. It's about 50% of the population. The least common is your hypersthenic. It's about 5% of the population. Now also, when we say sthenic and hyposthenic, that's your average normal body shape. The majority of the world are sthenic and hyposthenic. Versus the hypersthenic and asthenic, that's what we call our extremes. Hypersthenic being your very obese patients, asthenic being your extremely skinny patients. Once again, sthenic is the most common, hypersthenic is the least common. They're actually in order and commonality there.
So stomach is the most popular?
At 50% approximately. I believe hyposthenic is about 35%, asthenic 10, and hypersthenic 5. Did I get that right?
That's
Yes.
right.
Yeah.
Sounds like a test question.
And so the hyposthenic is the
The star is there.
Sounds like
Hypersthenic.
a test
Sure.
question. That your
Because
standard-
hypo is more of an average shape as well. Very easy to mix those up, by the way. Two very similar, all three are very similar words, guys. Be careful on that. I did list the percentages, but I think it's in your book. Make sure you hit those percentages, and we'll say them again. Sthenic is 50% of the population. Hypo is 35. Asthenic is 10, and hypersthenic is 5. I'm trying to put stars on the slide. When you see my stars, guys, it's stuff that I've had reported to me that they've seen on the registry. All right, here's a table right here, guys, is showing you those percentages as well as how those organs lie. So take a look. We have our two average types right here. The sthenic being 50% is what all of your models in the book are being based upon, because it's the most common body shape. And look, even though that body habits barely changes, like they're very close in size. Look at how extreme the stomach begins to elongate right here. It makes a big difference. So if we were doing fluoro exams on the stomach or the intestines, we have to adjust how we're centering based on that body habitus. Now look over here to a very skinny person. This is your asthenic. Look how low the stomach goes. This is the pelvis right here. So it always throws people off whenever they get a patient in fluoro that has a asthenic body habits, because it looks like their organs are about to fall out of their body. Like the intestines and the stomach are like down in the pelvis, literally. It's one of the weirdest looking things if you've never seen it before. And then, of course, that other extreme is your hypersthenic, your very large and wide or more obese patients. The stomach and the intestines get very wide in how they sit in the body. So, sorry?
This is unrelated, but which of these patients would you assume suffers from like acid reflux or something of that nature?
Acid reflux.
Like,
I mean, that's
like-
kind of common all across the board. It just
like
depends on
the stomach doesn't cause any difference in
It's
that? or-
more. I have acid reflux really
Oh.
bad, so that's just that can happen to anybody.
Okay,
Yeah, it's not really a body habitus issue.
okay.
But also look at the heart. You see how it's a little less extreme. The heart changes shape as well. See how long the heart gets on a skinny patient versus a hyposthenic patient. These are hypersthenic patients. It doesn't show you the lungs, but I think I have some X-rays of the lungs to show you what that looks like as well. But keywords here, because we usually focus a lot on the extremes when it comes to these organs. Asthenic, the organs become very long, elongated and low. Hypersthenic, the organs become very wide, stretched out and wide, horizontal. So the organs are more vertical shaped in the asthenic, more horizontal shaped on the hypersthenic patients. There's just another picture there showing you a side-by-side view of hypersthenic versus asthenic. It's your two extremes again. Look at the lung sizes. And it really does vary that much between your patients. So this is why we're going to learn about our crosswise versus lengthwise cassettes. Have you guys seen the cassettes in the lab? 14x17s?
Yes, yes.
So based on what you learned in that last lab, what kind of cassette orientation would you likely use on a hypersthenic patient because they have the wide lungs?
The landscape.
A crosswise or landscape view versus our asthenic, very long,
Portrait.
lengthwise portrait view. Yes, so we gotta know to be able to turn that accordingly depending on that size of the patient. Otherwise, what we're gonna do, if I get a crosswise cassette with a patient like this, I'm gonna cut the lungs off. I'm more likely to get all on one if I use that lengthwise cassette orientation. Yes?
Does this have anything to do with people that have like short torsos or long torsos? Like would you use a longer cassette?
Yeah, and usually you can see that as well, yeah, yeah. And once you look at those organs, how low they go. I've seen them go lower than that. I mean, like I said, it looks like sometimes their organs are falling out of their body. It's pretty weird looking. But it's healthy. It's normal.
So,
Yes.
doesn't bring your bladder and everything down, like, you know how it is when they say the organs come down.
It doesn't have any kind of health effects. No, it's normal. It's just it just
Without-
varies greatly. Yeah. Yeah. Oh, there we go. Yeah, there's the lungs. So A is going to be our most common type. There's your sthenic patient, the most typical type of lungs you'll see on a daily basis. Slightly different, but the hyposthenic, that's your second most common. Here's the ones that I hate right here. Now this was didn't get it all in there. They cut off the costophrenic angle. This would need to be repeated. That would be our asthenic patient, those very long lungs. And then your hypersthenic, very wide lungs. Now turn that cassette orientation again. You
So
got it
how
all there.
is, which portion is the lung, the wide, the great portion? Or how are you seeing this wide and?
See how long it is compared to up here? It's like thin and long. And look how wide and
The
spread
black
out.
portion, sir?
Mm-hmm. And we'll hit this again when we get to the chest anatomy. I just wanted to show y'all what that looks like. We're going to look at this more specifically with each area we go over, and how those organs actually lie in relation to the body habituses. Okay, so now we're going to move on to a lot of vocabulary here, guys. Here's all that vocabulary I was talking about. We're going to talk about osteology. What was osteology again?
Study of bones.
Study of bones. So what are we going to talk about? We're going to talk about the skeletal divisions, general bone features. Yes, we're going to go over bone development again, back to A&P, back to high school really. And then the classification of the various types of bones that we'll be talking about over the next 2 years, of which there are a bunch. That's how I feel right now this summer. This is like one of the worst heat waves. My grass is like crunchy in front of my house. And I was so proud of it because I was taking such good care of my grass, and even with watering it, it's just Nothing can survive this heat.
But it did rain yesterday pretty well.
A little bit.
Not in my house.
No, 5
It was
minutes.
a
Don't you
lot
know?
near my house.
Oh.
Can you send it my way, please? All right, what are the functions of the bones? I have them all in red for you right here. 6 major functions. They're going to be the attachment points for muscles, the mechanical basis for movement. They actually protect our internal organs. They support the frame of our body. Storage, and that's probably the one, those last two are the ones people forget about the most. Storage for calcium, phosphorus, and other salts, and production of our red and white blood cells. You'll often forget that your blood cells are produced within your bones. Red and white blood cells together in that medullary cavity that we're going to talk about here in a second. All right, big numbers here, guys. Big star, guaranteed registry question of at least one of those 3 red points I have highlighted for you there. There are a total of 206 bones in the body. 206. They are divided into 2 main groups, the axial skeleton versus the appendicular skeleton, of which they have their specific numbers as well. The axial skeleton is basically your head down to your coccyx, the mid area of your body. The appendicular skeleton is all of your extremities, like your arms and legs, and feet and hands and wrists and ankles. The axial skeleton, there's 80 bones. Appendicular contains 126 bones. Those come together to make that big number of 206 together. So what's the purpose of the axial skeleton? It's going to support and protect the head and trunk. Appendicular is how we move around, how we walk, how we move our arms, means for movement. Know those numbers. And that's just showing you the 2 sections right there, guys. The blue is going to be your axial skeleton. Once again, from your head down to the coccyx, the midsection of the body. Appendicular is going to be your extremities and your pelvis, clavicles, your scapula, everything's going to allow you to move around. Appendicular versus axial. Oh, there's your, yeah, I just switched the colors there. All right, so bone features. Let's talk about the parts of the bones. Our compact bone. When we talk about compact bone, that is that outer dense layer around your bones. Where I'm running my hands on this humerus right here, that hard surface on the outside of that bone is that compact bone. It's that protective feature of our bones. It's a hard, dense outer layer. The spongy is going to be the inner, like if I cut that bone in half, and you've got some great pictures in your book, is that inner, less dense layer. It contains what we call a spiculated network of trabeculae. It's pronounced trabeculae. When you look at these little indentations on a bone at X-ray, all these little, looks like little webby, I always think it was like little webs coming together. That's the bony trabeculae. We're seeing that spongy bone within. Compact is the outer layer. If I'm running my fingers along this bone, the outer layer. Internally, there's that spongy bone with the trabeculae found within. And those trabeculae specifically are filled with the red and yellow marrow, bone marrow. Does anybody know what bone that is, by the way?
That is the
Femur. It's the femur. It's the femur. Oh, not the femoral head, wrong end. That's close to your knee.
That's not the knee portion?
That's the portion where the knee is. All right, so what's the red and yellow marrow do? Specifically, red marrow produces our red and white blood cells, while the yellow marrow stores our fat cells. Now, in the central portion of the bone, I got a cross section to show you on the next slide here, is what's called the medullary cavity. That is our central cavity of long bones specifically, not the other types. We're talking about long bones here. So you have different categories. It also has a trabeculae with the yellow marrow, while the red marrow is typically found at the ends of the long bones. So yellow marrow is found in the central portion where that medullary cavity is. Red marrow is at the ends of the long bones. We say long bones, once again, that's mainly our extremities we're talking about, like femur, humerus, tib fib, radius ulna, things like that. Feel like we're in high school again? It always comes back.
Are we going to be talking about like osteocytes and? Or
We're not going to go that far
Okay.
back. Unless you just want to learn about it. I mean, I can throw it in there, but they don't require you to know that part, thankfully. All right, then we have what's called the periosteum. Periosteum is a thin sheath that goes around the bone. It's provided for connective tissue, mainly connecting vessels to the bones. I always think of it like a wrapping paper around the bone, that's what am I trying to say? Shrink wrap, like
Yeah.
thin shrink wrap around the bone. It's a thin layer. It's around that compact bone area. Then the endosteum is what lines the marrow cavity, specifically that medullary cavity. Like I said, most of them are hitting vocabulary here. Let's do a bunch of slides here. And there's most of the ones that we've named there, guys. There's a few other terms in there that we're going to hit. But once again, compact bone, there's your outer protective layer. Inside, you have that spongy bone where the red marrow is located. There's our little trabeculae that we talked about. And then that central portion of the long bone, where the yellow marrow is that medullary cavity, lined by that endosteum. And there's that sheath around the compact bone that we call the periosteum, like that shrink wrap going around it. It's that attachment point for blood vessels, nerves, things like that. Do you know how to label these on a diagram?
Somewhat.
Say again, do you know how to label those on a diagram? It's in your book. By the way, does anybody know before I hit it, because I love talking about this stuff, what's the epiphyseal line?
They haven't developed yet for kids.
You're close.
Growth plates.
It is a growth plate, yes. So that is where the bones seal as you grow up from a kid to an adult. Because as we know, when we're kids, our bones are all separated, they come together, they ossify, and they create what we call an epiphyseal line. That's where it seals together as an adult. You can see that in a lot of your x-rays on a lot of patients. You see the epiphyseal lines. We gotta be able to identify those because people make the mistake of thinking those are fractures. The last thing you want to do is be in clinic as a new student, like, wow, look at that fracture. It's actually a epiphyseal line, and the tech's laughing at you. It's not a fracture, sorry. But they look like fractures sometimes. All right, so there we go. Bone development, ossification. That's a term that applies to our development and formation of the bones. That's your direct definition. Know that definition. Very important one there. When does it begin? The second month of embryonic life within the womb. The processes that take care of that development are what we call intermembranous and endochondral. So this is an example of a pediatric long bone right here. There's your epiphyseal plates. That's that line we just looked at. But when you're a baby, they're separated. It's filled in with cartilage. As you get older, they ossify and come together and forms that epiphyseal line that we just looked at as you get older. Go ahead and write these down. We're going to specify these as well. We're talking about long bones, specifically with pediatrics. The ends of the bones are called the epiphysis. The central portion is called the diaphysis. The ends are called the epiphysis. The central portion is called the diaphysis.
Is there
Yes.
still cartilage there, or no? As
Right
you
here
grow-
where the epiphyseal plates are, yes.
As you grow older, the cartilage.
Oh, it seals.
Oh, okay.
So, yeah. Comes actually, it compacts together as an actual bone, so a lot of that cartilage does disappear. By what are those little areas within the spongy bone called? Trabeculae. Who's looking at that word? Trabeculae. Bony trabeculae. All right, so when we talk about different types of bones, we have what's called long bones, flat bones, short, irregular bones. Flat bones specifically are formed by what we call intramembranous ossification. It's a specific type of ossification. It's unique to flat bones. The short, irregular, and long bones are going to use that endochondral ossification. You don't need to know exactly how those work. Just know that's the processes of which they go about formation with the bone categories. Flat bones, intramembranous. Short, irregular, and long use the endochondral ossification. Now, endochondral does further go into two other categories. We have what's called primary and secondary ossification. Primary versus secondary ossification. We'll talk a little bit more about that moving forward. So here's an example of a pediatric knee. And if you didn't know what an epiphyseal plate was, or growth plates, like I said, you might get excited and say, wow, look at that fracture right there. That's totally normal. It's supposed to be there. Those bones haven't fused yet, even though it kind of looks like a fracture. Very important if you go into pediatrics, because we got to be able to identify fractures versus growth plates, especially in abuse cases, because you see a lot of stuff like that in pediatrics. There's those ends of the bones once again, the epiphysis. The long portion is the diaphysis. Yes?
Are there ever cases where there is a fracture like near the growth plate? Where
Oh, yes. I've seen them like split in half right here in the corners. Specifically for abuse cases, you look for little corner fractures. I got some pictures to show you actually,
Okay.
what that looks like.
And if we notice something like that while we're taking the pictures, we
You
zoom
want
in
to
and
you want to document that, absolutely, yes. Because even though the radiologists, they'll catch it, sometimes they won't. You know, covering your tracks, you're helping a patient through a bad situation, hopefully.
Why do you look in the corners?
Why do you look in the corners? It's just a very common fracture point with abuse cases. I'll show you here in a little bit. I got some examples of it. All right, so there's those two classifications there, guys, the primary versus secondary ossification. When we talk about primary ossification, it's beginning before birth, and that's going to form that long central shaft of the long bones, that diaphysis area specifically, long central portion. Secondary ossification, that occurs after birth. So primary before birth, secondary after birth, and that's when the separate bones begin to develop at both ends of the long bones that we also call the epiphysis. So ends of the bones, epiphysis, central long portion, diaphysis once again. So in other words, if I was going to think of another way to ask that question, the diaphysis forms during primary ossification, the epiphysis forms during secondary ossification. Running out of time here. I want to keep going. I'm enjoying this section. I love talking pediatrics, so. So there we go, guys. There's an example of a couple more pediatric patients. Well, the left is an adult patient, the right is a pediatric patient. This is showing you how we can sometimes still see those epiphyseal lines, even after they ossify. You're not going to see those on every patient, but do y'all see the line right here? And right here? You want to make sure you know that that is a sealed growth plate. It's not a fracture. Now looking over here, you can see those really distinct growth plates on his pediatric hands. Look at the ends of the bones here. These little bones that are detached, they're going to seal together as the patient gets older. Right here as well, there's those epiphyses, diaphysis. Epiphyses, diaphysis. And here's your little carpal bones. So we have 8 carpal bones. There's only 3 right here. That's the end of the radius right there that hasn't fused. And there's your ulna right there. And we already identified 2 of these carpal bones. That's your capitate and your hamate. That's likely either the lunate or the scaphoid right there. We're going to learn all those carpal bones next semester. And right here, I want to show this picture on the right. I'll talk about that in a second. Over here on the left is just another example of a pediatric patient. That's a humerus. You can see how those bones have not fused yet. There's those epiphyseal plates down here as well. And this was from a former student of mine who she's currently working at Texas Children's. And this was a really cool case that she did. These babies were fused at the pelvis, and they shared a digestive tract. So they had to do an upper GI on this patient, these two patients, these twins, to see where those intestines linked to try to portion it off for both the patients as they separated them. Make sure they both had working organs. So they actually did a whole fluoro study looking at the internal workings of the small and large intestine, and they cut the babies apart, and they're both doing well. You'll see some crazy stuff like that. I always say every time you think you see it all, you see something new. And this is an example of some of the abuse cases which you look for. You'll start to develop an eye for this. For pediatrics, we look for what we call rib fractures or healing fractures of the ribs. They typically look little bubbles like this. And that typically happens because when it comes to abuse, they'll typically grab a baby by the rib cage and they'll either shake them or they'll squeeze them and crack the ribs. And that's typically what that will look like. You ever see that on a baby or a pediatric patient, you want to make sure that that has been noticed. It's usually very indicative of an abusive situation. Over here, these are those corner fractures I was talking about. Typically, when they're pulling on the baby's leg or they're getting really rough with them, they usually grab the extremities. Like if parents just being abusive, they'll like shake the legs like that, shake the arms. They call these little corner fractures. This is a twisting fracture where they'll take the leg and twist it. See this a lot actually. And then skull fractures are very common. You can see right here where the sections of the skull have begun to separate. It's typically from slamming the baby down in a bed or slamming them against a wall. So what happens a lot.
Is that what that indention is on the back of the skull?
Right here?
A little bit
Right
lower,
here.
like towards the end of that
No,
back?
that's normal. That's the way they're shaped. But sometimes you'll see indentions from it caving in because if you ever felt the baby's head, they're very soft. There's lots of cartilage in there. But of course, abusive situations, it can cause a lot of damage. You know, it can cause permanent brain damage. So some of the stuff you'll see, you'll learn to identify. But you want to report this stuff if you ever see this kind of stuff out there in the clinical area, because you will get some pediatrics in Harris Health as well. They do come in. If you ever see something like this, what they'll typically order is what's called a skeletal survey, which means you'll do an x-ray study of all the bones in the baby's body, head, skull, arms, fingers, toes, everything, because they're looking for one of those healing fractures, see if there's a history of it. Usually they can deduce how long or how old the fractures are based on how it's ossified together, and they can determine when the abuse occurred, if previous abuse occurred. So, love working pediatrics, but you see some sad stuff too. That kill the mood for the class with that? It usually does. All right, so this is probably the slide we're going to end on today. I don't have enough time to get into all these, but we're going to start getting into the actual classifications of the bones. We have 5 major categories we're going to talk about: your long bones, your short, your flat, your irregular, and your sesamoid bones. And we'll break each of those down and give examples of each as well. That's going to classify all the bones throughout the entire human body. 5 major categories are classified by shape. That is where I will stop today. Any questions on the material? Yes.
I know you said we're not going to talk about it, but sesamoid, I don't think I've ever heard of that.
Sesamoid. So sesamoid bones, I always call them sesame seeds. That's how I want to remember it. Sesame seeds, like little seeds in your bones. Typically, you'll find them near your fingers, near your toes. And they usually develop due to friction. Where you have friction areas on the body, they're little supplemental bones that will form with connection points with tendons and ligaments. The largest sesamoid bone, though, in the body is the patella, the kneecap. That's considered sesamoid as well. They're round shaped. That's why I call them sesame seeds, little sesame seeds.
In high school, I believe we called them irregular. Is sesamoid like a newer term? Or?
No, sesamoid. That's irregular is going to be like your vertebrae and your facial bones.
Oh, I see.
So all these vertebrae have very unique shapes. That's why they call it irregular. Facial bones are all very unique in shape as well. That's why they're also called irregular. And
So then
sesamoid.
digits would be considered sesamoids as well?
The what?
Digits? Like the fingers?
No,
or-
not the fingers. No, they're
Those are short.
under long bone actually.
Classes and the
Yeah. But we'll break all those down on Friday. Any other questions? So one of you asked how many questions on the test next week. So right now, it is at 75 questions. I'm probably not gonna go beyond that. Now, I heard some of y'all make some noises. But hear me out. This is a part of the training process. Because your board exam, does anybody know how many questions are on your board exam? 230. So we've got to start early training ourselves to take larger tests. Because there's such a thing as test fatigue. Your brain gets tired. If you do not train yourself to take these higher level tests that are longer, if you go, like, imagine I gave you 50 question tests through this entire 2 years. You go sit down for your 230 question test, what do you think is going to happen to your brain? It's going to shut down after you get through 50 of the questions. So we're going to train doing larger tests to train our brains to be able to last that long. Because it's hard. It's hard taking larger tests, but it's also more points for you too. More points to work with. That's why you can expect every test moving forward, at least in my classes, to never be less than 50 questions. I'll say that. But this one's going to be 75.
Any
Most
question,
likely.
time limit would be, sir?
Say again?
The time limit
Sure.
would be?
You'll have the whole 2 hours of the class to
2
take the test. Plenty of time for 75 questions, guys. Plenty of time.
Do you give bonus questions?
Do I give bonus questions?
That'd be nice for the beginning.
I typically, well, I don't want to spoil it. You'll see. I'm not gonna give away my secrets. You'll see. Yes.
Is there like a spot where we can find out grades? How do we know what grade you have?
You're gonna be signed up.
Sounds
Has Mr. Fong signed you up on Praxis School? I'll let him know. It's gonna be on what's called Praxis School. We'll get you guys an actual account. You'll be able to pull your grades up. Yeah. I'll make sure to remind you to get that set up for you guys.
Your test on exam soft
It'll be on Exam Soft. Yes. Please get that set up. You have a test with Mr. Fong on Friday, I believe. Yes.
Yeah.
So make sure it's working before the test on Friday, and of course we'll be able to troubleshoot you if you're having issues. We'll also do a test review next week as well. So
Your test cover what chapter?
1 and 2.
1 and 2. So what should you be doing? Well, you need to be reviewing your info. Please review your notes. Even if you're going to look at it for 15 minutes before bed, go back into your book and supplement your notes, compare them. It's a strong study technique, but don't wait until Tuesday to study for this test, or you will not do well. You've got to start studying now. You've got to keep the information fresh. That's my best advice to you. Do not cram. If you're not cram, next year in school. I learned that the hard way because I was a professional crammer through both the college and school. And I got to X-ray school and I couldn't do it anymore. You've got to stay ahead. You've got to stay on top of it. Start getting some study groups together. Review this information we've talked about. Start drilling yourself. Make flashcards. But don't just use those notes as a wall decoration. Go back and look at them. Supplement it in your book, and you'll do good. You'll do good. Read your questions carefully. Remember what I said? We're going to read questions 3 times before we answer. Look for key terms. You'll be successful. Yes. Question?
Mr. Fong said you want a hard copy of the workbook? Or do we just bring you our workbook?
Yeah.
So good question. So the workbook, bring me your workbook pages on the test day. I'll walk around and check those while you're taking your test.
Okay, so we don't have to make a hard copy?
No, just bring me your copy, set it on your desk, and I'll walk around and check it while you're taking your exam. Easy 100, guys. Don't forget those workbook pages. Either an easy 100 or an easy 0. Simple as that.
I did mine since I have mine online. I printed it. It has like the printing on like the watermark on it, but you can still like.
That's fine, as long as I can tell you did it. And those of you that have the printouts, I'll provide you the answers to those as well. I'm trying to get those out to you soon. So, by the way, when you're doing your workbook, guys, don't just flip to the back of your book and look at the answers. Try to take it legit, because your workbook has the answers in the back of the book. You didn't know that?
Thank you.
I think you just shot yourself in the foot.
I should have kept my mouth shut.
Yeah.
That's the first thing I always do on a workbook. I look to see what's in the back of the book. Well, now you know. Don't do that though. Try to take it legit first and then check yourself. It's a good way to gauge. And we'll say why, guys. It's a good way to gauge where your weaknesses are and what you need to focus on your studies. If you know it, you know it. Leave it alone. What you don't know, that's what you study. That's another study technique. Don't obsess on what you already know. If you know it, you know it. Find out where your weaknesses are. Focus on the weaknesses. And you'll be more successful. Trust me. All right, guys. Thank y'all. Good class. I think Ms. Shepard's going to have some scenarios for you guys to role play in the next class for patient care. I might slip in and watch that a little bit, but I'll be in my office all day if y'all need me. Any questions, let me know. Thank y'all.
Wait, Mr. Donahue,
Yes.
I don't think this workbook has the answers on the back.
Does it not?
No.
I thought I was.
Mine did.
That is.
Is this the teacher edition?
I'll have to see.
Because the last one's wrong.
That's actually a good thing if the answers aren't in there. It's gonna give you better study habits. Maybe it's because I have the teacher edition.
So can we get the answers?
Well, how much
Or
is
at
it?
least
How much is it
know
worth
what
to
we
you?
got wrong.
Oh, that's the
Let me see.
counter offer.
Let me see. Try to do it legit.
Yeah, mine
It's
is
gonna
like-
help you. Trust me.